requirement that for people to maintain their medical license, they'll have to do 2 hours of CME related to opioid use and opioid alternatives for pain control. We are working out the final details of how you would need to document attendance at the 2 grand rounds that we've had this fall that relate to that requirement. And we'll send a really detailed email to our entire grand rounds listserv and put it on the website once we have that ironed out. We didn't want to have you do something prematurely and not fulfill the requirement. And please don't worry about it. It's not due until 2022. So you have over a year, lots of time to fulfill the requirement, and I will make sure you get many, many reminders about how to do that when the time comes. So with that being said, it's my pleasure to introduce Dr. Jakob Guenther, who's a member of our Pediatric Anesthesiology group here at the University of Minnesota Masonic Children's Hospital. He is incredibly well trained, having completed anesthesiology training both in Germany and then at the Medical College of Wisconsin, where he did his residency and then his pediatric anesthesiology fellowship. He's been a really active teacher and mentor since he joined our faculty, giving numerous lectures to students and residents and mentoring those who are interested in anesthesia. He also has a special skill set that might be of interest to many, in that he is a epic super user and builder. He said he's actually gone beyond the super user phase, and just would encourage any of you, he's not able to build things for you. He's very, very busy doing that. But if you're interested in what it might entail to build your own skills in Epic and take charge of some of those things that bother you, he would be a great resource to talk about how he got into contributing to clinical care in that way. So we're really delighted to hear more about opioid alternatives for perioperative pain control in pediatric patients. Welcome, Dr. Guenther.
Thank you very much for the kind introduction. I'm just going to put up my slides here. Find the share button again. Here we go. Are you able to see the slides?
Yep, looks great.
Looks good, thank you.
Yeah, yes, thank you very much for the kind introduction. Just a caveat, in the age of COVID, my kids are at home, so if somebody barges in, I apologize in advance for that. As mentioned, I'm going to talk about opioid alternatives for perioperative pain control in pediatric patients. And to make it clear, I also do not have anything to disclose. The overview for this lecture, it's going to be a run through several topics. I will briefly touch on certain pain concepts for perioperative analgesia and pain management. And then we'll cover several topics that include regional anesthesia, including neuraxial and peripheral nerve blocks. And then a part of this lecture will also include what you might encounter on the floor when you have patients who have either had a block or have a continuous infusion with local anesthetics. And then I will attempt to round that up with other non-opioid pain control options. I will mostly or specifically only talk about pharmacologic measures today. So it would be too much outside and time to fit the other options, like the non-pharmacologic options of pain control in here as well. Starting with analgesia strategies. The overall thought process of treating pain is a combination basically of preventing pain and then to actually treat the pain. If you look at the slide here, you may see several options that we have available. These options range from not treating pain at all, treating pain only after patients have been exposed to pain, post-surgical analgesia, treating pain before it even, or preventing pain before it even happens. And if you look at the scenarios A, B, and C, in all of these cases, you will see there's quite a bit of a chance for pain development, and specifically hyperalgesia or hypersensitivity development. It turns out that the best way to treat and to prevent pain is basically a combination that allows us to treat pain before it happens. Typically, regional anesthesia is a big component in this setting, and then treat the pain as it happens afterwards if there's breakthrough pain or all these things. So with a combination of preventing and treating pain, we get the best results and the least development of hypersensitivity. When it comes to pain treatment afterwards specifically, it does help to have some planning on board. There are three modalities how to do that. The first option is just PRN dosing of pain medications whenever pain occurs. While it gives some time where you have adequate analgesia, unfortunately, it often creates time periods where you actually go into pain and you first, at the point of time, then you give the pain medication. So patients might remain in pain for quite a while. If you try to maintain an optimal serum concentration, you have several options by giving a regular bolus, by using sustained pain, like using medications that have a sustained release, or to do a continuous infusion. These options can be challenging because it's sometimes a bit hard to predict what the pharmacokinetics will do for each individual patient. And so you might be hovering at the range where you're getting into pain, so in the red zone kind of. You might have quite a few moments where you get close to that. If you have a medication with sustained release, those periods where you're getting closer to the pain area are shorter. With continuous infusions, you might be able to prevent that. Having said that, even with the continuous infusions, there might be moments where we have breakthrough pain. This could be, for example, during PE or PT, or if the patient has to be moved, or there sometimes are just other factors that even with a continuous infusion create breakthrough pain. So the combination of using a continuous measurement or continuous measures such as regional anesthesia infusion, plus having backup medications available that allow to treat breakthrough pain, seem to have the best outcome to keep the patient as comfortable as possible throughout the process. All right, I will talk about regional anesthesia and analgesia at this point of time. Regional anesthesia is defined as a decreased sensation in a circumscribed region produced by the application of a nerve conduction interrupting agent, and therefore attenuating pain signals the brain receives from that region. Having said that, this is a concept that is being used both perioperatively and postoperatively. With pediatric patients, we rarely use it as a sole anesthetic because having surgery and being able to hold still during surgery while you might hear things is out of the range of possibilities for many children typically. And so we typically use regional anesthesia as an adjunct to general anesthesia and then continue to use it basically for post-op pain control. The role of regional analgesia is basically to decrease, not to annihilate pain and sensation. So based where we do the block, based how much volume of local anesthetic we use and what type of concentration or what type and how much concentration of local anesthesia we use, all these things define how dense and how well this block might be. Again, it is not meant as a standalone therapy. It is typically part of a multimodal pain approach, and other medications such as opiates, NSAIDs, adjuncts, and non-medication strategies can be applied on top of the block. So the goal is not to be entirely pain-free from the block. The goal is to get to a point where it's easier to control the pain and need less other medications, basically. All right, what are the benefits of regional anesthesia? Overall, when we use it perioperatively, we are able to reduce our general anesthetic requirements. This also means that we typically have less post-operative complications as a result of that. Often patients need less ventilatory support afterwards. This specifically is important for thoracic and upper abdominal procedures where taking deep breaths can be very painful. So if this area is fairly numb, patients can take much deeper breaths on their own. It allows us to take the tubes and tracheal tubes out earlier and has less respiratory issues afterwards. With the reduction in opiates, we see an earlier return of peristalsis, meaning we have less ileus with these patients. the overall stress response is decreased by using regional anesthesia. So you might see less hypoglycemia and less ADH release, meaning less edema and more urine production for these patients shortly afterwards. And this is being researched at this point. There might be an actual decrease in systemic inflammation after surgery. There is more research required. There were some studies that pointed strongly towards it, but then I just recently saw like a review where they said it's not quite as simple. So more research is required about the influence on the systemic inflammation with regional anesthesia. So what are the benefits of regional analgesia compared to Sedative? So what the result of the regional anesthesia is basically, obviously we can avoid opiates and all the side effects that come with opiates. We can have less of those. We have a fairly effective pain relief, and kids might be more cooperative when using these techniques. Regional anesthesia allows a fairly long-lasting or even a continuous pain relief. Like blocks can last up to 24 hours. Or if you give continuous pain relief, you have an option of up to typically 5 days of using that. And it is also helpful in patients who have chronic pain, specifically if they use chronic opiates or have a history of abuse with that, obviously not only in children. We may not be able to go below their baseline pain, but often we might be able to keep them at the amount of opiates they are used to and not have to add too much on top of it after an acute on chronic pain event, basically like surgery. What are contraindications to regional anesthesia? Some of them are absolute, some of them are fairly relative. An obvious refusal of the patient or a parent is an absolute contraindication. Severe coagulopathy is more of a relative one. We typically avoid doing neuraxial blocks if somebody has severe coagulopathy. With ultrasound techniques and experience, many of the peripheral nerve blocks can still be done, even if the patient has coagulopathy, just because we have a rough idea where the needle goes and to avoid significant bleeding that way. Local anesthetic allergy, I would call a relative contraindication. Most of the patients are actually allergic rather to the preservatives, and we have preservative-free formulations here. Patients might have spine abnormalities or a tethered spinal cord. This is also a relative contraindication. We just should have imaging before we do any pokes there to make sure there is a way to get there safely. And then if a patient has sepsis or an inflammatory response, we typically try to avoid catheters in these cases, but single shots are often okay to use. If obviously there is an infection at the site where we plan to inject, that is an absolute contraindication. Just a brief overview of the medications that we use. Luckily, cocaine is not part of the regimen anymore. We have some alternatives to that nowadays. The most commonly used ones are chloroprocaine, ropivacaine, bupivacaine, and then a version of bupivacaine that is a liposomal. Chloroprocaine is an amino ester. It comes in a fairly high concentration, and it is the only local anesthetic that we use that is metabolized by pseudocholine esterases. So it has a very short half-life. It is second in the bloodstream. In reality, we use it mostly in the epidural space, and the half-life is a little bit longer, more in the minutes to half an hour range. But the good thing is if it gets absorbed then eventually by the venous plexus in the epidural space, it has a very short half-life and has a fairly low toxicity from that perspective. Ropivacaine and bupivacaine both are aminoamides, come in much lower concentration, have therefore typically a slower onset of pain relief. And both of them are metabolized in the liver. The biggest difference in the half-life is that ropivacaine has a fairly consistent long half-life. Bupivacaine specifically has an extremely long half-life in neonates and infants, so we try to avoid it there for blocks, or we try to avoid it there for continuous infusions. We might use it for single blocks. Ropivacaine is more hydrophil, while bupivacaine is more lipophil. And with the ropivacaine being more hydrophil, it typically has more trouble to penetrate thick myelin sheaths around the motor nerves. So Typically, ropivacaine has less of a motor block, while bupivacaine gets a more solid motor block and sensory block, while ropivacaine is mostly a sensory block. Liposomal bupivacaine is basically a slow-release version of bupivacaine. We can mostly use it in adults only. Unfortunately, I hope that will come at some point for kids as well, but it seems to be more difficult to calculate the dose based on weight. There are other factors that play into that. In the adult blocks, sometimes we get up to 72 hours of pain relief with a single shot block. So that's basically has in many cases, we don't use it neuraxially, but we use it for peripheral nerve blocks, but it kind of has made many infusions less necessary, and you can just give a single block and you give up to 72 hours of pain relief with that. We may combine the local anesthetics with alpha-2 receptor agonists such as clonidine and dexmedetomidine. Clonidine is commonly used as an adjunct in continuous infusions. Dexmedetomidine is getting more and more popular, specifically in single shots, and we may use it in caudal epidurals as well as single shots. The one issue with it, there is a potential for crystallization when it's being mixed with local anesthetics if you store it long. And so typically we don't use it in infusions at this point of time, just because those syringes might be in there for like 48, 72 hours continuously infusing, and there are some concerns for crystallization with those. I will talk now a little bit about what happens when you give too much of local anesthetic, so basically a systemic toxicity or LAST. How can LAST happen? There are several options how this can happen. The classic approach is that somebody attempts a block, inadvertently enters with the needle into a vein or a blood vessel, and then not realizing it, giving a large bolus of local anesthetic that then quickly goes over the entire body and can create toxicity. In certain areas, specifically if blocks are being used in the neck area, there are a lot of arteries that go straight up to the brain. So even a small dose that might be given accidentally intraarterial might cause significant CNS toxicity because it's not getting dissolved first in the rest of the body. It goes straight and concentrated into the brain and can cause CNS toxicity that way. Other options include a fast absorption if you have a high large absorption surface and a high blood flow in the area. The classic scenario here is an intercostal injections where after rib fractures or so, where multiple little deposits are being made all around the ribs, and then with this creates a fairly large absorption surface and can cause toxicity. In contrast, for example, doing a foot block where you just really have one single foot full of local anesthetic, it's extremely unlikely to get toxicity just because the surface area in this is too small to really create toxic systemic levels. And then one option that can happen with small kids specifically is having like LAST as a result of a continuous local anesthetic infusion. This may be happening due to a drug calculation mistake. It may happen because the tip of the catheter wanders, even with movement and all these things, the tip is not solidly in place. It can get displaced into a vessel and basically then infused into a vessel. Or in general, the metabolic capacity of children just can get overwhelmed, specifically neonates and infants who may not have the liver metabolism capacities that adults have. How does it present? It typically starts with CNS toxicity. Sedation, blunt CNS signs, you may not see the first and early signs. So typically these signs come before you have hemodynamic changes, and the range is fairly wide. It can be tinnitus, blurred vision, dizziness, tongue numbness, numbness around the mouth, agitation, restlessness, muscle twitches, slurred speech, drowsiness, and then it can all result in unconsciousness, seizure, and respiratory arrest. Following CNS signs, you can have hemodynamic and cardiovascular symptoms. You may see changes in the EKG. You may have dysrhythmias that can go from bradycardic arrhythmias to asystole, to also tachycardic arrhythmia, including VFib. Local anesthetics have a strong negative inotropic effect. Specifically, bupivacaine is the biggest offender here. So you might have actually heart failure. Peripheral vessels might get involved as well. With lower doses, you may see constriction. With higher doses, then you get dilation and hypertension, and it can lead to cardiac arrest, essentially. So how to treat that? First of all, obviously, stop the offender, so stop the local anesthesia infusion injection. I'll talk about the management of that a little bit later in the lecture. If you have seizures, please use benzodiazepines as a first line of treatment. Propofol is contraindicated, and I will talk about that in a second. Secure the airway as necessary, and then if patients have ongoing and refractory seizures, you might have to give neuromuscular blockade to kind of keep them from having harm from that perspective. You follow the PALS or ACLS guidelines. However, there are a few exceptions. So first of all, if you already have local anesthesia toxicity, avoid further sodium channel blockers like lidocaine. Use epinephrine, however, in a significantly reduced dose, so basically 1/10 of the typical recommended dose. The idea is that the acidosis that can be result out of using epinephrine might actually worsen the local anesthesia toxicity. They're mostly protein bound, and acidosis might actually release them from the protein and make it even worse. We have one strong helper, and that is the lipid rescue therapy. Basically, we're using the same 20% lipid emulsion that we use for TPN. The reason why you shouldn't be using propofol is basically, first of all, it's only in a 10% lipid emulsion, so you would need to double the amounts. And then propofol in itself is also a strong, has strong negative inotropic effect. So giving that much propofol basically creates a lethal dose of propofol. So please stay away from propofol and setting up local anesthesia toxicity. Ventilate as required. In severe cases, you might have to consider ECMO or cardiopulmonary bypass in these patients. Here is the lipid rescue therapy dosing guidelines. So you start basically with a 20% lipid emulsion. You start with a bolus of 1.5 milliliter, not milligrams, milliliter per kilogram, and start an infusion after that. And then you basically assess. If you have ongoing cardiovascular instability, you can repeat the bolus with another 1.5 milliliters per kilogram. Once you reach a stage where you are hypotensive but have a return of spontaneous circulation, you can still double the infusion to 0.5 milliliters per kilogram per minute. And then once you have received cardiovascular stability, you can basically go back to 0.25 milliliters per kilogram per minute, continue the infusion for 10 more minutes and monitor for 12 hours. Overall, you're not supposed to give more than 12 milliliters per kilogram, but that allows 2 boluses and probably 30 minutes of running it at half a milliliter per kilogram. So there's quite some time with that. It is surprisingly effective if local anesthesia toxicity is really the cause of the hemodynamic instability. There is a high percentage of patients who come back with good neurologic outcomes. How does it help? First of all, it absorbs lipophilic local anesthetics, specifically bupivacaine. It makes it less likely to bind to receptors. It acts as a direct energy source to the myocardium, so it basically allows the mitochondria to create more ATP and therefore more cardiac output. The triglycerides increase the myocardial calcium concentration, therefore also making it easier for the muscle, for the heart muscle to pump. It has been in case reports been used with other lipophilic drugs, basically. So it may not be a silver bullet, but there have been case reports about other toxicity. As long as the drug is lipophilic, it appears to have an effect there as well. Talking a little bit about nerve blocks and catheters, I'll start with the peripheral nerves in this case. One of the most commonly used ones at this point are paravertical blocks, and those blocks are basically just outside the epidural space. So if you look at the picture here, you kind of see the spine, and the needle is being advanced basically past the spine or right in the space next to the epidural space, and you can inject local anesthetic there or thread a catheter in the space. You can cover up to 2 up to 4 segments with that. If you run this at a fairly high dose, you can do it one-sided or two-sided. This is typically used for thoracotomies, pectus repairs, or upper abdominal procedures. The little brother of the paravertebral block is the Erector spinal plane block. So instead of going past or deeper than the spine, you actually stay outside the spine here where the arrow goes, and you inject a local anesthetic between the erector spinal muscle and the transversus process. And from there, the local anesthetic can travel along the spinal nerves and create very similar numbness and analgesia than the paravertebral block does. Overall, the same indications as a paravertebral block. It has since you're staying further out, it has a very low adverse event risk. So this block has become more and more popular over the last years. Plane blocks in general have become more and more popular. The idea of a plane block is not to target a specific nerve, but to basically find an area where multiple nerves are crossing through, for example, between muscles. The most common block that we use is the transversus abdominis block. So if you look here at the picture on the side, this is basically the abdominal cavity. You go through the wall of the abdomen and you try to find the layer between the transversus abdominal, which is it's the deepest muscle, and the second layer, the internal oblique muscle. And you try to lift that fascia between those two muscles up and fill it all the way with local anesthetics, and all the muscles, all the nerve endings, the nerves that pass through there will receive some numbness. It can also be used in other areas. Quadratus lumborum is an option, rectus sheath is an option, or it can also be used in the chest area at the pectoralis muscle. We typically use it mostly for abdominal procedures, pelvic procedures, or length incision, and it can also be used if, for example, it's being done under laparoscopic view. It helps there as well. Brachial plexus blocks are not very common in peds, so I'm just going to spend 30 seconds on that. The more or less message is where it really very much depends where you access the brachial plexus to get pain control for different areas. The higher up you go, the higher up on the arm you will receive numbness. So the interscalene block creates mostly shoulder numbness, while going further down with a supraclavicular or infraclavicular approach, or the axillary approach, you can reach the arm, the forearm, and the hand respectively. Femoral nerve blocks, again, not super commonly used in children, maybe in adolescents for knee surgeries. The classic approach was to go right below the inguinal ligament, and because we have a very classic anatomy there with the nerve on the outside, the artery, and the vein going towards the inside. Now typically we use the adductor canal block, which is a little bit further down the leg. It just has an overall lower complication rate. It has less of a motor block and mostly really numbs up the area rather than makes it impossible to move the leg. These blocks are typically used for knee procedures and fractures. With some experience and some ultrasound, it is essentially possible to block more or less every nerve of within the body. Other typical locations for nerve blocks include the sciatic nerve, the popliteal nerve, the saphenous nerve, foot block, as mentioned before, and then typically individual nerves in the hands can be blocked as well. The median, the ulnar, and the radial nerve, basically. Switching over to neuraxial anesthesia. Neuraxial anesthesia was invented or first researched by these two guys. Dr. Corning had probably the first epidural injections, and he did those in dogs. He thought initially he had done an intrathecal or a spinal injection. However, looking at his writing and how long it took for the block to come up, and there was no CSF reported to come out, he likely was more in the epidural space. Dr. Beer from Germany actually supposedly did the first intrathecal or spinal injections. The story goes that he and his assistant tried those on each other and then were super thrilled. They used cocaine for those. They were super thrilled that they were able to basically feel no pain, and they used hammers to hit against their knees, and they used metal prongs to squeeze their testicles, and it didn't hurt until obviously the effects of the spinal anesthesia wore off. And the other part of that is that they didn't have specialized needles, so they had significant post-punctual headaches, basically. And while the attending, Dr. Beer, was able to kind of take a week off, his poor assistant basically had to continue his rounds with those severe post-punctual headaches. Mostly Erector blocks are being used at this point of time or the most common use is probably in the OB section, but we use them quite frequently in the pediatric section as well. Intrathecal anesthesia is basically an injection into the CSF. We typically have a lumbar approach just to avoid hitting the spinal cord directly. It is a very fast onset, and you have a blood quality that includes temperature, pain, and touch as well. It turns out that using continuous infusion in the intrathecal space has a fairly high amount of neurotoxicity, so we stay away from this nowadays. And we really rarely use it in peds at this point of time. There are some centers who use it fairly routinely for short hernia repairs or something in children where there's a significant concern for apnea, for example, in preemies. But at this point of time, we have not really established that because it needs cooperation really with short cases. It has to be a very well thought protocol because you maybe only have 45 minutes of spinal anesthesia time in little children. They metabolize the stuff a little bit quicker, or it seems to not have a 2 or 3 hour effect like we have mostly in adults. What we mostly use is the epidural approach. So using the epidural is basically right outside the dura mater. And we can choose a caudal approach, lumbar approach, and a thoracic approach. In the long run, it doesn't really matter where you poke. It really matters where does the tip of the catheter end up. And that's where you will have most of your analgesia afterwards. Epidurals take a little bit longer to set up. It can take up to 15 minutes to really have an effect. The blood quality includes temperature and pain, not so much the touch sensation. The caudal epidural is basically just another epidural, but we use the lowest possible point that we have to really access the epidural space. In this case, it's going through the sacrococcygeal ligament. And in peds, this is the most common place where we use it. This ossifies more and more as we get older, so it's harder to do that in adults. One of the reasons why we want to go as low as possible is that the conus medullaris just goes lower down in children compared to adults. So we're trying to go in as low as possible. It's a very simple technique that can be used with landmarks, or it can be used under ultrasound approach. Sacral anomalies are a relative contraindications, so just having images to make sure that there's no tethered spinal cord or so are recommended before doing that if there is a suspicion of having any sacral anomalies. As mentioned before, it matters more where you thread the catheter. From there, and under ultrasound or fluoro guidance, you're actually able to thread catheters from the caudal location up to mid or high thoracic levels. When do we use caudal and epidural anesthesia? It is most commonly combined with general anesthesia after inductions, and single shots can be used for most procedure in the lower abdomen or in the pelvic area, hypospadias, orchiopexis, hydrocele, and so on. As mentioned before, it matters not only how many milligrams of the medication you give, it also matters how diluted that medication is. So on the one hand, you might have a less denser block if you dilute it more, but giving diluted local anesthetics allows to use higher volume, and therefore the spread of the local anesthetic within the epidural space is much higher. You can have a far higher spread of local anesthetic and therefore a much bigger analgesia area. Catheters are being used if we anticipate significant pain. And as mentioned, we can guide those under ultrasound or fluoro into the mid-thoracic or lumbar levels. They're mostly being used for large abdominal procedures, especially if we have a midline incision, and then also thoracotomies for And even in small kids for TEF and congenital diaphragmatic hernia, those can be used successfully. Now we're going to talk a bit of management and troubleshooting, and I try to make a focus on things that you might deal with on the floor. So I most talk about your management options and when we would like you to call us, basically. Just to give you an idea what complications there are, there is a network called the Pediatric Regional Anesthesia Network, and they kind of review data to see how safe are blocks for children. As of 2015, that's where the last data was released, they had several thousand peripheral nerve catheters in children. While the adverse event rate seems fairly high at 12%, most of these events are catheter malfunctions, block failures, infections, like or mild skin infections, or initial vascular puncture without having injected the local anesthetic with that. It is very unlikely to have any persistent neurologic injury. There has not been any LAST reported, and there haven't been any severe infections reported. Infection rates are extreme, like systemic or that are more than skin infections, are extremely rare, and especially if you use catheters less than 3 days. Overall, the adverse event rate is very similar to adults, and so they recommend that pediatrics can utilize peripheral nerve catheters. If you look at the overall complication rate, and this includes then peripheral nerve blocks as well as neurexal blocks, the by far most common complication are benign catheter-related failures. For example, catheter falls out, the catheter doesn't work as well, and this can happen in up to 4% of the blocks. Skin infections are at 0.5% of the blocks. Transient neurologic deficits become even more rare. LAST is extremely rare. However, having said that, the majority of the cases in the pediatric world occurred in infants, and probably most likely then with an overwhelmed metabolic capacity. And epidural abscesses or hematomas are extremely rare. Overall, the PRAN, or the Pediatric Regional Anesthesia Network, concluded that it is fairly safe to do these blocks in children under general anesthesia, so after they are basically deep sleep, and it is obviously a little bit easier for children to tolerate those blocks then. All right, what to do when you have to deal with these? And I'll talk about several topics. Topic number one is if you have pain in spite of a block. And you may find us, or our regional team, then come up to the floor and plunger your ice machine and put ice all over the patient's body, just to find out where is a loss, where do we have less of a temperature sensation. And our goal is to basically, where the surgical incision is, have less of a temperature sensation. If it seems like we are not in the right range, if the numbness seems to be outside the targeted area, what we often do is a local anesthesia bolus, and the reason for that is explained here. Why they look like turds, they are not turds, I can assure you of that. Those are actually pictures of how local anesthesia spreads in the epidural space. And it turns out that giving a bolus creates a much better spread of local anesthetic than giving a continuous infusion. So specifically in small kids, we give infusions that run at less than 1 milliliter per hour of a rate or so, or like between 1 or sometimes 1 or 2 milliliters per hour. So this dribbles in so incredibly slowly that it just doesn't really spread well in the epidural space. On the other hand, if you give like a bolus that spreads out much further, your pumps kind of have are utilizing this concept, and they don't for blocks, they do not give a continuous infusion anymore. They basically give an hourly or like a 30 minutes interval boluses. That seems to improve the overall efficacy of blocks. At this point, we don't have these pumps here, but we are on the way to get these pumps here as well. Obviously, then afterwards, you might have to adjust the catheter dose. You may have to pull back a bit on the catheter, or if that really doesn't work at all, you may have to replace the catheter. The epidural space is a fairly complex space. It's can be septated and compartmented. So if the tip of the catheter ends up in one of these compartments, it might just not fill up the entire epidural space, or the catheter tip might go left or right through one of the foramens or foramina in the spine. The therapy for a one-sided block is very similar. We basically try it with a bolus. If it doesn't work, we might have to pull back on the catheter a little bit, but that's kind of the second option. What can also happen is that the block seems to be in the right space, but just the patient still suffers from pain or from too much pain to tolerate that. In this case, we can either use a higher concentrated version of the local anesthetic, or we can add clonidine or opiates to the mix. As mentioned before, it is not meant as a sole and only an analgesic regimen. We recommend and even encourage to combine our blocks and epidural blocks with breakthrough pain medications. This can be NSAIDs if allowed. This can be opiates at that point of time. But it overall hopefully will decrease the overall amount of opiates required. What are the responsibilities of the teams? So the regional anesthesia or the acute pain team is currently only managing catheter-related therapy. So if you have a catheter that that runs a local anesthesia infusion or has clonidine or opioid into it, that's where the RAPS team comes into play. At this point of time, when it comes to scheduled pain meds or breakthrough therapy, this is the responsibility of the primary team. We're always happy to help with recommendations. So please, if you have somebody who has a local anesthesia infusion, you would like to adjust your pain regimen, we're always happy to give recommendations. But right now, the official responsibility to write the orders is still in the hands of the primary team. What to do if you find a catheter, either epidural or peripheral, if you find it leaking? The most common so if you find a leak, so basically around where the insertion site is, we typically ask you to continue the infusion. We may ask you to add some Tegaderm or sterile gauze around that so it doesn't kind of wet the bed or become contaminated. Please call RAPS and we will then replace the dressing. Specifically in small kids, the catheter might only be like a centimeter or so into this epidural space. So if you try to replace the dressing, you might inadvertently remove that. It can happen to us as well, but we'd rather blame ourselves than anybody else. So you can fortify the dressing, reinforce the dressing, but please do not replace it. If you see erythema, swelling, or pus around the catheter site, just call us. We will take a look at that and then decide if it's worth to continue the block or not. So we would ask, even at this point, to continue the infusion at this point. If, however, the catheter becomes disconnected, the most common culprit is shown here on the right bottom. It's typically this clamp that that connects the patient side of the catheter with the pump side of the catheter, and if that comes apart, then it can get disconnected. We ask you to clean the patient side of the catheter that is now open and sterile with chlorhexidine and wrap the exposed catheter into a sterile Tegaderm until we can take a look at that. Please avoid reconnecting or injecting anything into this catheter. If the catheter can be saved, we will do that. We might cut off a piece and then continue. If the risk seems too high from a risk-benefit ratio, we may have to pull the catheter. But again, this is something we would like to handle basically. You may encounter patients complaining about motor and sensory deficits, which, to be fair, we want to reach with using a regional anesthesia. When a patient specifically has arm and leg blocks, we just ask you to help the patients to use common sense techniques to avoid injuries. So use padding around numbed extremities, because they might not have a feeling where it goes, they might slam it against doors or the side of the bed. And then make sure that when you have somebody with a lower extremity block or a lumbar epidural, that just discuss mobilization goals with RAPS so they don't have falls. If you have worsening numbness, weakness, tingling, or shooting pains that weren't there before, this might be a concern for an abscess or hematoma, so please get the pain team involved. Having said this, hematomas and abscesses are extremely unlikely to occur. If you have an erectile block and the patient starts to complain about numbness or shortness of breath, you might actually have like a high block that reaches now the levels of T3, T4. So just give us a call about that. We might have to reduce the running rate a little bit there. We are typically not too concerned if there's ongoing numbness, weakness, or tingling for up to 24 hours afterwards, specifically if a block has been running for several days. So up to 24 hours is fairly common, and we don't have too many concerns about that. If patients become sedated, this can happen if patients with epidurals have clonidine or opioids included with that. Call us before you stop the catheter there. Often these patients have other sedating medications involved as well, like fentanyl, dexmedetomidine, midazolam, and it is worth to first decrease or stop the other sedating medications before you stop the epidural catheter. However, obviously, if there is any respiratory issues, we ask you to support the airway at that point of time. It is expected to be very rare. On the other hand, if you have a catheter that has only local anesthetic in there, those guys should not be sedated or have any altered mental status. So if you have somebody without any sedating medications in there, if you have no other obvious source for an altered mental status, that would be a moment where you have to think about local anesthesia, systemic toxicity. So in this case, we would ask you to stop the catheter and immediately call reps. We would typically ask you to at least give us a chance to discuss the use of lipid rescue therapy before you start it. That if you obviously have a reason that the patient is going into hemodynamic instability, that's a different story. But in all other cases, we would ask you to talk to reps first before you start lipid rescue therapy. Patients may get hypotensive. It's not so common in the pediatric world compared to the adult world, but what can happen with regional anesthesia is you get venous pooling by sympathetic lysis. Fluid boluses might help initially, and then again, please talk to reps before you turn the catheter off. If you have to give more support, that can be discussed obviously as well with pressors or all these things. Fever and sepsis. Typically, the epidurals or catheters in themselves are not the cause of abscesses or sepsis. They might sometimes question if you want to keep a catheter running during an acute sepsis, but it's extremely unlikely that the catheters are the source of the sepsis or the fever. So in these cases, we would ask you to continue the infusion until you have basically talked to reps about it. All right, what to do when the therapy is completed. Some patients require Foley catheters, specifically with lumbar epidurals. Those can be removed whenever you think they don't need those anymore. If you have a peripheral nerve catheter, those can be removed by the floor, by the nursing staff at direction of reps. And we just ask you to maybe take a peek at the injection site an hour or two, up to 24 to 48 hours later, to make sure that there's no acute infections. With epidural catheters, on the other hand, we would ask you to not remove them by yourselves. Just give us a call, and we will remove them when we deem that the therapy is completed. If a catheter comes out accidentally, we ask you to please not throw away the catheter, because we have to look and document that the catheter was removed completely. Sometimes shear forces can cause the catheter tip to come off, and having like a retained catheter tip in the epidural space might warrant a surgery afterwards. So we would really like to look at those catheters when they come out inadvertently, so we can take a peek at them. So if it happens, please ask whoever's taking care of the patient to hold on to the catheter until reps has been able to take a look at that. All right, how do you get a hold of us? The easiest way is, or how to get a hold of reps, the easiest way is to contact them via paging. So under regional anesthesia pain service, you will find providers, and that also includes, if you look here at the third line, the regional anesthesia pain service. This is just another Jakob in our department, and this was just a random choice from 2019. So there are more options, but this is basically the easiest way. Otherwise, you can use the in-house pager with a job code of 0602. This one only accepts phone numbers, no text pages, unfortunately. And just to clarify, REPS is not our chronic pain team, or like REPS is not the CRNA on call, and REPS is also not the pediatric anesthesiologist. While we might be able to help you, to connect you to REPS in case you really cannot get a hold of REPS whatsoever, we may not be able to intervene. We might know what to do technically, but it's outside our responsibility, and we're not supposed to interfere with the blocks that REPS has placed or is managing. So those would be really only your absolute backup options in case you really cannot reach anybody at the REPS team. All right, I will make sure time-wise. I will briefly talk a little bit about other non-opioid pain control options. I just mentioned Tylenol just to point out how different the dosing is depending on the route that you're using that. While it's fairly established with oral and rectal, there are, especially if you use the IV version of that, you have completely different age and weight ranges. And I would just like to point out that until 2 years, technically, using IV Tylenol for pain is an off-label use. And then looking at age and weight, and 13 years less than 50 kilos and 13 years over 50 kilograms, it's just sometimes worth to take a little peek at the instructions again before you really use it, because it can vary in its dosing and all these things. NSAIDs include ibuprofen and ketorolac at this point of time. We use ibuprofen typically at 6 months or older. There is an IV version out there right now. We do not have it available yet, but I hope at some point it might be available to us for standard perioperative pain control. That is, it might be there for PDA closures and all these things. Having said that, they're using Tylenol for that as well now, it seems. Ketorolac is very effective, but it is technically an off-label use in children under 17 years. We still use it because we don't really have a good alternative with IV ibuprofen not being readily available for us, but just keep that in mind. For most pediatric patients, this is an off-label use. Dexmedetomidine is probably one of the most commonly used drugs at this point of time. We can use it as a pre-medication, we can use it perioperatively or as a continuous sedation medication, or to add it to single shot blocks. It also has the benefit of decreasing nausea, agitation, and pain after anesthesia, basically. Ketamine works via NMDA receptor blockade. Other drugs in this with the same effect include magnesium, dextromorphin, and methadone. It has sedative and analgesic capacities. We can use it for pre-medication, intraoperative, and post-operatively. Having said that, the overall effect using it 24 to 48 hours seems to be somewhat limited when it comes to opiate sparing. So we typically don't use it too much in pediatric patients as an infusion afterwards. It has, over the last 10 years, gotten quite a bit of use in psychiatry. It appears to be able to lift patients out of suicidal ideation within hours, where other medications may take weeks or months to work. And I am going to conclude this lecture with a brief mentioning of intravenous lidocaine, which is very, is kind of one of the most recent and most hyped things to avoid opiates. However, and this is just came out in November this year, actually, there's an international consensus statements, and I think I just put the most important part in there for us as pediatric providers, that basically says intravenous lidocaine should not be used in patients weighing less than 40 kilograms. So I think for now, we'll use that very, very scarcely in the pediatric population. And with that, I would like to conclude my lecture. I would just like to give a special thanks to Molly Hagen from the pain team, who is tirelessly and always working with us and helping to keep the children comfortable in this hospital. Thank you very much for your attention. I appreciate you being here in the morning.
Thank you so much. That was excellent. We've got time for a couple of questions. Dr. George from our ICU group asked, how much time do these procedures, I think we're probably referring to some of the local anesthesia options, add on to OR time, and do they reduce length of hospital stay?
If everything goes fairly well, most of these procedures can be done within 10 minutes, basically. And then if you have, for example, 2 blocks, because like if you have to do a bilateral block, this might add another 10 minutes. Having said that, it can add more if it's complicated. So I don't think there is a direct link between, I don't think there is a direct link between a discharge time. Having said that, there is definite data that shows that we have less ileus and can extubate earlier. So if you can decrease the time for these critical conditions that you need to discharge a patient, there may be a link, but I don't think it's specifically studied to in the pediatric population, at least, if there is a definite decrease in admission time.
Great. This one comes from anonymous attendee. Thank you for the excellent talk. A comment and a question. Prior to Minnesota, I had an experience where a pediatric doctor pulled an epidural in a child on heparin, and the child ended up having a significant bleed and long-lasting neurologic deficits. So they're echoing your point that doctors who don't put in epidurals should not pull out the catheter. That's their comment. Their question is on a different topic. What are your thoughts about Propofol alone in the emergency room for painful procedures like setting a fracture in an extubated child?
So the problem with Propofol is that it is basically providing general anesthesia, and that's kind of a system-wide discussion we're having right now. What is sedation? What is general anesthesia? It is hard to, and it requires experience to use Propofol in a way where it's only sedating. And if you're just using it for sedation, there are other safer options, basically. It is very, very easy to go into the range of general anesthesia with Propofol. And this then, so it can suppress respirations, it can suppress, it can have cardiac effects, even though in heart healthy kids, those are very minor and typically can be neglected. So as an anesthesiologist, I'm hesitant to propose Propofol as a standalone drug in a setting where you want to sedate with it, because crossing the line from sedation to general anesthesia is sometimes very hard to manage with Propofol.
Great, thank you. Anonymous attendee, I think, would like to have a longer conversation with you about Propofol that I don't think we have time for today, but just a question about pain control with Propofol in sedative doses. So does it have pain control properties when you're using it at that sedative dosing range?
It is not considered an analgesic medication. It is really meant, and by definition, if you are under anesthesia, you cannot feel pain, because pain is an active sensation, kind of, that you need to be awake to have pain. Yes, you might suppress sympathetic surge if you do general anesthesia to somebody. On the other hand, I think over the last, when I first trained in Germany, we used Propofol kind of a lot in the ICUs over there for long term. I think we have moved a little bit away from that. Propofol in the long term in high doses can interact with mitochondria and can cause the so-called propofol infusion syndrome. It is rare, but it basically can create lactic acidosis and a failure of mitochondria. So in the short term, basically, if you have an acute pain event, for example, having surgery, it is very helpful from that perspective. I'm not certain if it's a long-term, and we have better options to create sedative effects than propofol. Dexmedetomidine comes to mind, has a nice sedative effect, has an analgesic effect, has an overall decrease of sympathetic surge effect. So there, I think there are better options out there than propofol per se.
Great. Well, thank you so much for the excellent talk. We really appreciate you being here, and I wish everyone a wonderful Wednesday. Have a great day.
Thank you very much. I appreciate it.